So the podcast today is from an article that Christian sent me. We're going to be talking about gluteal tendinopathies, or basically just, I think in general, hip pain on like the side of your hip, and discussing, I guess, the diagnosis and treatments and all that stuff. I think the main part of the article was breaking down myths and misconceptions surrounding this type of pain. And we'll kind of dive into each myth and discuss our own thoughts, what the article said, and of course, kind of break it down into, easy to understand terms, and give some practical advice where we see fit. But before we dive into that, I want to just give a quick update. Yesterday, I did my first like heavy leg day since the meniscus injury 5 weeks ago, and it felt so good. I didn't do a whole lot. I did split squats, cat. I feel like I say this wrong every time. Kazakh
Oh, Cossack.
squats. Cossack. Yeah, I say that wrong every
Side
time.
lunges.
Side lunges, Cossack squats, and then like pretty heavy RDLs on the barbell. And I'm feeling it today, but it just felt so good to get under some heavier load again. And the knee handled it pretty freaking well the whole time. So that was really exciting to see, and feeling good this morning.
I mean, that's super, super good.
Yeah.
Still just blown away with how quickly you've been able to recover.
I
Obviously, you're just a specimen.
It's in my blood, man.
It's in my
It's
blood, Minnesota blood.
just that Viking DNA, dude.
Are you doing any plyometrics or running yet?
I've been doing like walk jogs. So I've been doing probably about 2 to 3 minutes of a jog, and then cooling it down to a walk, and then back and forth. And it's been feeling good. I might, after we get off here, I'm going to go to the gym and keep focusing on the upper body because we're still trying to hit 315 on that bench.
Can't forget
And
that.
I'm going to try maybe a little bit longer jogging intervals on the treadmill today and see how that goes.
Yeah, great. Yeah, you're obviously killing it. Very happy for you. No
Thanks,
locking,
man.
no buckling, no
No,
instability. You're having the ideal recovery where like, yeah, it sucks for the first week or two and then things begin to get better. You're working through it. You're shifting your goals accordingly to help keep your sanity and move the needle somewhere. And you're just seeing the fruits of your labor. And of course, your
100%.
body's natural
It
healing
just,
properties.
oh, yeah, absolutely. Anyways, so let's dive into the podcast here. Um, Christian, why don't you just quickly, I guess, set the stage around what what the anatomy is, what we're kind of looking at here. Like when we talk about the hip, especially in this part of it, the hip kind of has different parts of it, especially muscular wise, right? Like we have anterior or front musculature, we have lateral or side musculature, posterior musculature, pelvic floor musculature. Like there's so much different things when you say the hip. It can, regard many different things. So when we're talking about gluteal tendinopathies, what are we really talking about?
I think the best place to start is going to be with the three major gluteal muscles. So when you think about your glutes, you have the backside, that's your big butt cheek, that's your gluteus maximus, and then on the side of your hip, you have your gluteus medius and gluteus minimus. The two that we're really talking about today regarding gluteal tendinopathy are the gluteus medius and minimus. The big butt cheek muscle, your maximus, we don't really see clear issues with that one typically. It seems to generally do really well, kind of like the deltoid in your shoulder. The deltoid, larger muscle, generally is fine. It's usually going to be the underlying stabilizer muscles, like the rotator cuff in that example. So, sticking with glute med and glute min, the major issue that we have with those or with that area is that the tendon of those muscles that attaches to the side of your hip on a very large bone called your greater trochanter, that tendon is often involved in a lot of different painful conditions. So there are so many different things there that can have a problem, like your gluteus medius or minimus tendon. You have the greater trochanter bone itself could be irritable. You have bursa there. There's the IT band that also goes over there. There's tons of things around that area. And because there are so many things, it's hard for us to often say it's this one structure that's the problem. And we gave it a name a while back called greater trochanteric pain syndrome to try to encapsulate all those different structures that could have a problem. But that name is kind of doesn't really mean anything to a lot of people. And I find when you say that to a patient, that term often is more confusing. It's a mouthful. It's not pointing to a discrete structure. And everyone, patients and us therapists, want to be able to say it's this one thing that's bothersome for you. And while greater trochanteric pain syndrome is probably a more accurate phrase, it's not very constructive. And so generally, thankfully, it's almost always the gluteal tendons that are the problem. And so we generally will call it gluteal tendinopathy. But
Yeah.
these muscles and tendons are incredibly important for your overall stability of walking and running. They help keep your pelvis level when you're standing on one leg, and they're vitally important to impact-based activities like running, sprinting, jumping, landing. And if you don't have sufficient strength in the muscles and or the tendon, that will often lead to you getting some pain on that outside of your hip.
Yeah. Yeah, no, I couldn't have said it better myself. No, that's a great introduction to it. So, yeah, one of the things that I was kind of thinking of when you mentioned greater trochanteric pain syndrome, I mean, first of all, I think if anything, it makes it sound cool, whipping out that big old phrase. But it reminds me of like subacromial pain syndrome, right? Like
Right.
in the shoulder. Like we used to call it shoulder impingement, and then after years of research and clinical trials, we're like, maybe it's not really impingement. Let's just call it subacromial pain syndrome, which is basically saying something in this place of the body is painful, irritable. We don't know exactly what it is, but this is what we're going to call it, which leaves it very vague and generalized. I mean, I guess the good thing is, coming from like a physical therapy perspective, it allows you, I guess, to keep your options open in terms of your plan of care, because you're not just cornering yourself on one specific anatomical structure. Or I think sometimes as a physical therapist, or as physical therapists as a profession, we can get very tuned in of like, I think it's this one thing that we need to fix. And you just kind of get pigeonholed, and then weeks go by and the patient isn't getting better, and maybe you're missing something because you right away got so tuned in on one thing. So I think from that perspective, it's good that we kind of keep a more open idea of what could be going on. But like, I totally agree though. I tell my patients all the time, we want to find the smoking gun in the room, right? And work on that. And I think this article that we're about to get into does a really good job of breaking down how we can identify that and what's actually going on. So let's get into the first myth here. The first myth is trochanteric pain, so on the side of your hip, is due to bursal or bursa inflammation. So like you said, Christian, there's a bursa underneath the tendons around or on top of that greater trochanter. And the idea of what a bursa is it's this fluid-filled sac that is around different like busy places, right? So we have bursas everywhere in the body, and the idea is it helps provide a kind of like a frictionless environment so that we don't have these types of injuries. And I just want to start off with what the research article said in terms of the reality of it, which is, and this is taking it pretty verbatim from the research article, but gluteal tendon pathology is the primary cause of lateral hip pain. Bursal involvement is often secondary. About 20 to 30% of the time, we get bursal involvement and gluteal tendon involvement. The article goes on to say only 2 to 8% of the time, we have isolated bursitis or inflammation, irritation of the bursa. Only 2 to 8% of the time. That's pretty crazy. That number is a lot smaller than I thought initially when I read this first myth. 2 to 8%.
Well, especially because you hear all the time doctors or physical therapists
All
or
the time.
chiros saying, "Oh yeah, you have bursitis." I'm like, "No, you don't. Like, no, you don't." Or
Yeah.
if you do, like you're the 2% that somehow has it but doesn't have a gluteal tendon issue. It just
Yeah.
But that's just like this is I guess a quick aside. It's more, I know that we kind of said that there's all these different structures in the area that can be the source of your issue, and it really doesn't matter a whole lot. it truly doesn't matter because the treatment is more or less the same. These different issues, whether you have a bursa involvement or you have a bursa plus a tendon or just a tendon, it's all different manifestations of the same issue. You have an outside of your hip or a gluteal structure overuse issue. Either you're overtraining it or you're overtraining it with insufficient recovery. And one or several of those different structures are becoming sensitive to that work, and we have to figure out how to fix that. But by and large, the treatment is more or less the same. But
Mm-hmm.
one reason I do think names are important is they instill certain thoughts in the patient's and the therapist's mind. If you tell your patient that they have bursitis, what do they think that is? They probably think that is going to be inflammation and swelling of this thing in their hip. So where does their mind go? They're not going to get better unless you correct the swelling and the inflammation. So what does that mean? They're probably going to take tons of NSAIDs. They're going to be like, okay, do I ice it? Do I have to avoid using it completely, or else it's going to keep staying swollen, being more inflamed? And the name that you use, the label that you apply to the thing, matters because it changes the way the patient thinks about it. It changes the way the therapist or the doctor goes about treating it. And that's the main reason I think the name is important. But other than that, it doesn't really change a whole lot if you actually know these different kinds of numbers and the stats behind it.
Yeah, absolutely. And just taking it elsewhere in the body. I mean, we see it all the time in low back pain, right? Patients come in, they're like, yeah, my primary told me I have degenerative disc disease and, you know, facet arthritis and my back is just falling apart, blah, 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 blah. It's like, well, all right, let's break this down a little bit. Let's talk about the numbers and the statistics and let's not make this so life threatening to you. It's kind of the same thing here. You're right. And it's actually really interesting. The article goes on to talk about how there's actually very little of these cases have like swelling or inflammation going on. It goes on to talk about how the gluteal tendon is actually most of the time it's a thickening of the gluteal tendon at the insertion point that is from these compressed loads. And I think it even talks about friction as well, which, side note, one of the things I thought about with the whole friction side of it, and I think we'll get on, I'm hoping to remember this for another myth coming up because it talks about clamshells in the near future here. And I'm excited to hear your take on that. But it talks about this idea of friction. And I kind of have a hard-ish time like coming to terms about that because our body, our muscles, the fascicles, everything it's surrounded by fascia, right? And fascia is this frictionless environment. And so I have a hard, maybe someone, an anatomist, if that's the correct term, could correct me and enlighten me. But how do we have frictional forces in a frictionless environment that is causing these thickenings? Now, compression, that's a different topic. That like, yeah, that could absolutely happen. But anyways, it talks about how there's these different cellular processes that can lead to this gluteal tendon thickening, and likely that's more of the reason why we're getting this lateral hip pain versus some inflammation or bursitis that's going on.
I think of the thickening more as the classic disorganization of tendon fibers argument, where if you have this chronic or repetitive overuse of the tissue and it doesn't have the chance to fully recover and adapt, the tendon fibers ideally should be very straight, very in line, minimal space in between them, tightly packed, because that's going to provide the best ability to transfer force. But when you have that insufficient recovery, that overuse, the fibers get crooked, they get bent, they get more space in between them because your body's holding more fluid between the fibers. And so that makes the overall structure of the tendon enlarge, and that's that disorganized or larger environment. And that's mainly going to be a sign that the tendon is insufficiently adapted for what you want to do. And then it's our job to figure out how do we continue that adaptation process, move it more favorably over time. And that's going to come from a sneak peek exercise that we'll get to later.
Absolutely. I love it. All right. Myth number 2, gluteal tendinopathy only affects postmenopausal females.
Well, I
This
guess I'm
is,
a postmenopausal female because I had this shit like around Christmas. I know I told you guys about that in different podcasts from
yeah,
standing too long playing video games. So
dude,
definitely a myth.
Wait, first of all, you stand while you play video games?
I did for a while because I got tired of sitting. I decided to stand for way too long, and then I gave myself some tendy pain.
Some tendy pain. Well, that's where I'm messing up. That's why I'm so bad at Call of Duty. I'm not standing while I play. I'm sitting all the time.
Hey, you're just gonna give
Uh,
yourself sciatica.
I know. God, I need to stop sitting so much. So, um, I didn't know that this was a myth. I didn't know that this
Me
was
neither.
propagated throughout the healthcare industry that only affects postmenopausal females. Yeah, I think for one of the things that I thought of is I'm like, all right, if this is really going on out there, here's my take on it. Before I even read this section, I think we're using correlation to make causation in this case. We're saying that we're seeing a high predominantly demographic of people who have this diagnosis are older females post-menopause. It must be from hormonal changes from menopause. And it's like, well, let's back up a second. Or maybe it's because we know that females have different, slightly different anatomy when it comes to the hip and pelvis region, which can put different loads on the gluteal tendons. And now we're thinking they're older, maybe they're a little bit weaker, they're still doing stuff they were doing 10, 15 years ago, and it just catches up to them versus some type of hormonal change. And I think it goes in, it talks about, I think it discusses like lower estrogen levels and, tendon remodeling and how like that might influence it. But by and large, that is not the sole factor as to why someone might have this. And if you're a 30-year-old male, like Christian and I are, absolutely, you can get gluteal tendinopathy. That is not out of your wheelhouse that you can't get it. So yeah, this is definitely a myth.
I will say though, it does happen more in women. That is anecdotally, I came into this knowing that,
Yep.
or believing that, I should say. But even the article cites a couple other studies out of a lot of different people, like many thousands of people that they observed and examined, and it certainly happens more in women, especially of that age. But Eric, I swear you stole my notes because I was going to say the exact same thing about other possible reasons than hormonal changes, such as the one that we'll learn about a lot in school is going to be the Q angle. It's just the angle
Yep.
your legs make when you stand. So we all know women generally have wider pelvises, and so as they get their feet under them when they stand, their angle or their thighs make a more of a triangle shape as opposed to like a rectangle shape, and that triangle shape puts more stress on your glute tendons. Now, I'm not saying that is clearly a risk factor and to what degree. That's just like where my head went when I first read this was it's probably more the way you're built and the way you're made than it is the hormonal changes causing this observed thing where women have it more than men.
Yep. Agreed. All right. Anyways, that was a quick one to move on from. Not much to discuss there. Myth number 3, palpation of the greater trochanter is sufficient for diagnosis.
Who also thought this? I don't understand.
I don't know, man. I mean, I will say that I unfortunately I've seen like notes from like orthopedics and whatnot, and I am maybe a little bit too oversimplifying this. I don't know what's going on in their evaluation. I wasn't there, but from what I read, it's like, like everything checks out except for the patient has pain in the lateral hip, therefore bursitis or gluteal tendinopathy or something like that. And I'm like, okay, maybe people are just relying on palpation to the greater trochanter for being painful, being a sufficient diagnosis. My first thought on this, Christian, was I absolutely think that we should have confidence in our ability to palpate and find structures, especially for someone like myself and for you who are going to be taking your dry needling course soon. Like, if you're going to be sticking needles into someone, you better frickin' know where you're sticking the needles. But in the same sense, I think we are fooling ourselves a little bit. And now the greater trochanter is very easy to palpate and the glute very easy to palpate. But even with that being said, we know that there's studies where doctors have palpated individuals in the lumbar spine or the cervical spine, and they're like, this is the structure I think it is. And then they do like imaging afterwards, and like they're not right. And this idea that we just have this x-ray vision and we know exactly where we're palpating, I think that like that alone is unreliable. Just being like, yep, nailed it every time, 100%. I know what I'm feeling. Like I said, we should have confidence and we should trust ourselves and our clinical skills. But I also think that just relying on our palpation skills alone for this diagnosis is, I don't know, like it says, insufficient. And also just to say, yeah, you hurt here, so it has to be this. There's a lot of other stuff going on there that it could be.
Yeah, and then the article did go into making sure that you're looking for your other differential diagnoses. So for those listening, if you have pain on the outside of your hip around your greater trochanter, yeah, chances are it probably is gluteal tendinopathy, but it also could be coming from very deep inside your hip joint. It could be arthritis referring out. It could be a labral tear referring out or a cartilage issue doing that. It can be coming from your low back. So low back pain can refer to the outside of the hip. You can have an organ issue that can refer into your low back, pelvis, and hip. So we're always looking for those kinds of things too.
Yep.
But
Yeah.
yeah, under no circumstances is palpation sufficient for diagnosis. That's why you have to combine it with other tests that we know work pretty well, which this article does go into detail with, where they propose a 4-test battery, which makes a lot of sense to me. But one is palpation, where if you press on the area and it hurts, okay, let's put that one in the bucket for having gluteal tendinopathy. If you don't have tenderness on that area, the research around that is actually pretty good in saying that you probably don't have it. So if you are tender there, you might. If you don't have it, you don't. That was the first test. Other test is going to be testing the glute muscle. So like make the person use the muscles, push on your leg, force a contraction. If that contraction is sore or recreates your pain, especially in that spot, that's a pretty good sign that you have the thing. Another one is going to be standing on one leg, trying to keep a level pelvis for 30 seconds. When you stand on one leg and you're keeping a level pelvis, you're making those glutes work to hold you up so your hip doesn't drop, you don't fall on the ground. And so if you get sore while doing that in that same spot, that's a good test. And there's one other test where we twist your hip around and then make you do a weird muscle contraction. I'm not going to describe that one, but that one's also a pretty decent test. And then you put all those 4 different things together, including the patient's report of how everything happened, what they're feeling, where they're feeling it, the kind of pain, and then you get a pretty good idea of what the condition probably is.
Yeah, spot on.
And they even said doing just palpation will bring your diagnostic accuracy or causes a diagnostic accuracy of about 59%. If you add in the other tests we mentioned, it brings your accuracy to 96 to 99%. That's a big jump. Like that's the kind of diagnostic accuracy you want to see anywhere.
Yeah. I tell patients there's a vestibular test that you can do, the GANS SOP, that if it plays out the way it does, you have like upwards of 90% confidence that someone has a vestibular hypofunction. And I tell patients that have that they're positive with it, I'm like, look, there's not many things in physical therapy we can be over 90% sure on. And so, having something like you talked about, that battery of testing in the 90 percentile, that's pretty good. So anyways, yeah, absolutely. More stuff than just palpation when it comes to diagnosing gluteal tendinopathies. All right, moving on. Myth number 4, diagnosis and management should be based on imaging findings. So taking an image, seeing abnormalities in the area, and being like, yep, nailed it, we got it, gluteal tendinopathies. What I thought about first is, imaging, we know this with low back pain, imaging does not correlate with pain. It can be a great tool for a lot of stuff. And I'm sure in this case, there's cases that can be properly diagnosed with imaging. But I think it's important to do the things you talked about, Christian, in terms of looking at other things, functional movements, different muscular tests, and trying to figure out like, all right, you have pain here. Maybe imaging shows something positive, but you're not presenting the way we think you would present with a gluteal tendinopathy. And it even goes on to talk about how gluteal tendinopathy findings are common in asymptomatic individuals 50 to 88% of the time. So if you take an image of someone's hip and they don't have pain, 50 to 88% of the time, individuals who are asymptomatic might have a change in that gluteal tendon. And now we might be overly diagnosing someone and telling them that they have it and just making the situation much more complex.
Absolutely. This is a thing that we say almost every podcast, that your imaging does not define you. It is a useful tool. It is something that we use, especially its its best utility is going to be looking for very scary stuff. Do you have a break? Do you have a tumor? Those kinds of things. That's where it really shines. But when it comes to vague things like a gluteal tendinopathy, it's somewhat useful. I think the article said that people that don't have gluteal tendinopathy and don't have pain usually don't have an imaging finding. But people that do have gluteal tendinopathy almost always do have some kind of an imaging finding. It's
Yeah.
just that you can have that finding and not have pain, just like you said. So you
Yep.
can't rely on it. It's not that useful, honestly. And this is sometimes tough for patients to hear, because everyone, like we said before, they want to know the one thing that's going on, the one treatment and how to fix it, but also what's the thing that's going on based on my image? Can you find the spot so I can see it and tell me? They want that clarity, they want that peace of mind, and it's just not a thing. It's not really useful, and trying to convince folks that we don't need that to help you get better is often really tough. But it's just that's a message we're going to have to keep saying almost every podcast until culture shifts in the next 20 years, when that's actually a thing in the zeitgeist.
We
Yeah.
I'm gonna start doing sit-ins at universities with t-shirts and saying that imaging does not correlate to pain. And the other thing too that I just want to throw on there is, like, let's say we take an image of the hip and it's like, oh dang, yeah, you also have arthritis in the hip. And it's like, all right, well now we're throwing more stuff in there. So now the patient thinks, oh God, I have arthritis, I have tendon changes, I have, all these different things going on. My hip is falling apart. How am I ever going to get better? Which, I mean, conservative treatment for these things work very well. I guess the point that we're trying to make is imaging can be so sensitive that we find things and we label things that may not have been the problem in the first place. And we just tax the psychosocial side of pain with these different imaging findings, and it can make the rehab process a lot more difficult than what it needs to be. But, all right, cool. Moving on, about halfway there. We said we wanted to make this a quicker one. We're trying to work on our speed, and we're at 30 minutes. So we're going to keep powering through. Number 5, gluteal tendinopathy is a self-limiting condition. I had a little bit of trouble because maybe I'm misunderstanding what self-limiting condition means, Christian. In my head, I thought that means you can do what you want as long as you can tolerate it. Like, that's self-limiting to me. Maybe I have that wrong in my head. But the article goes on to discuss that 50% of patients may recover in 12 months with basic advice. So just kind of telling them what to do and have them go do it on their own. But 50% have recurring or persistent symptoms. What are your thoughts on this section and the myth that gluteal tendinopathy is a self-limiting condition?
My understanding of self-limiting is that if you do not seek treatment, if you do not do anything special for this, it will go away on its own. That's self-limiting. And so when it comes to this diagnosis, about 50% of people, when given basic advice, they'll get better. And so that's more or less self-limiting. But half of them, the other 50%, don't. And these symptoms will persist until you do something about it, meaning that they're going to be there year after year after year unless you engage in the treatments that we know work pretty well. And even then, it isn't going to always cure you. That's what also sucks about this.
Mm-hmm.
It's the same thing for runner's knee. We did a podcast on runner's knee a while back, and that is also not a self-limiting condition, in that once you have runner's knee, you're going to have it. You have to do something about it to make it go away, and that can be years. So I actually didn't know that gluteal tendinopathy was not self-limiting. I figured there were some people out there that got better without doing anything about it because they naturally would alter their movement patterns. They would maybe do some exercise differently, all that kind of stuff. And I guess it sort of is true what I'm saying, because half of them seem to turn out okay, but those numbers were new to me.
Yeah.
And that's just more reason for us to make sure that when we see folks with this condition, that we really are trying to treat it. Because, if someone comes in with knee pain and you're working on that, they also, near the end of their care with you, are mentioning something like that they have the potential for gluteal tendinopathy. Leaving that unchecked might do them a disservice. You should probably be doing something about that if you haven't already with your knee stuff, because they might come back to you in a year, 2 years, 3 years with this issue, and it could be worse. So if you treat it sooner than later, it could be better.
Right. Yeah. No, you said that much better than I did. So thank you for doing that. So yeah. So anyways, the main point here is it's good to seek, I think, physical therapy care to work on this and to get it better. I think just even just more than basic entry level discussion about it. One of the things I think is so powerful with physical therapy, well, that should be so powerful, is that you should be well educated on what's going on. And I tell patients all the time that, it's an old adage, but knowledge is power. The more you know about the body, I think the better of a handle that you have on things. And so that alone, I think, is gives merit to seeking physical therapy for this type of diagnosis or pain. All right. Number 6, gluteal tendinopathy is due to a tight IT band, and treatment should include IT band stretches. We love to blame the IT band for a variety of things. So, anyways, they said that the reality of this is that the IT band tightness theory is questionable. And that one of the things that they discuss is that the IT band, if we are going to stretch it, what does that do? That adds more compressive load to the lateral hip. And what do we know can be causative to gluteal tendon changes? Compressive loads. So if we're thinking, oh, this is IT band, we need to stretch the crap out of the hip. The article says that stretching pretty aggressively for like IT band stuff might actually further or provoke the pain of the gluteal tendon.
Yeah, that's something that we know across all tendons in the body. Especially one good example is going to be insertional Achilles tendinopathy, where the tendon, your Achilles tendon, is attaching to your heel bone. As you do really deep stretches of the calf with folks that have that diagnosis, it can often make them worse because
Mm,
you're not just applying tension through the stretch, just the way the attachment site is when you stretch into that position, you're actually also providing a lot of compression to the tendon. And tendons seem to like, sore tendons especially, seem to like tension and dislike compression. And so that's why folks that have gluteal tendinopathy often hate sitting down for too long or hate lying on their side at night because they're literally compressing the tendon. That makes it irritable. And so we really try to avoid excessive compression. And IT band stretches or even glute med or glute max stretches when you have this condition, I'll sometimes prescribe them anyways, not usually IT band, but definitely the glutes, just because a very light, gentle stretch can provide people a short-term pain relief
hmm
situation. So I don't avoid them at all costs. I just never encourage folks to do them really hard and never do them into pain because I know that the compressive aspect can make folks feel worse. But I
Yeah.
think this myth, in particular the IT band aspect, just points to a larger issue in our industry, whether it's PT, it's chiro, massage therapy, etc., in that there are lots of well-intentioned people, I want to make sure I'm clear about that, who are trying to help patients. They point to tight fascia as being the reason that you're moving weird or that you're in pain to begin with. And if they were to fix or correct or improve that fascia and the mobility of it, that all your problems are going to be solved. You're going to be a lot better. The truth is, we really don't have a lot of evidence for this to be the case. Like, we don't know this to be true. We don't even know, in fact, that stretching, for example, doing calf stretches with Achilles pain or glute stretches for glute pain, if those things help improve your situation or even prevent future injury. So, like, the idea that loosening your fascia, loosening your IT band is helpful in the first place is just not really a thing. And it's also, it brings up a chicken and egg type question in that, do you have your pain in your hip because your IT band is tight, or is your IT band tight because you've been overusing or under recovered in that outside hip system, and now your IT band is feeling tight or sore in response to that overuse or insufficient recovery, more as like a guarding or protective mechanism. That's usually where my mind goes, is that this tightness is secondary to the underlying issue, not causing the issue.
Yeah. Yeah. Agreed. And they also go on to talk about we should consider other things. Talk about the Q angle. We already brought that up. Joint morphology, muscle structure, load capabilities, right? Like all these different things play a major role. And like you said, people have well intentions to get individuals better, but to just solely focus on one thing majority of the time, which would be, oh, your IT band is just tight and that's why we have to stretch. That can be a little misleading. And if you stretch it too much, you can actually make things a little bit more pissed off.
Yeah, I know for some people, they might be like, no one is actually telling people that, Christian. Like, no one is saying that you're in pain because you have tight fascia. No, they really are. At least in my area, patients come to me all the time and they're like,
Yeah.
oh, I know I got this pain. I've been told I have tight fascia. I'm looking for things. This is a real thing that happens probably weekly,
Yeah. All the time.
at least biweekly or monthly. I'm hearing
Yeah.
people tell me this. It used to happen more years ago. It's happening less now, thank God. But it's still a thing, and these are real myths that we have to bust for people.
Yep. Agreed. Agreed. I see probably at least twice a month people coming in with a diagnosis of like myofascial pain. It's not a bad diagnosis, but like people come in and they talk about how their fascia is just tight. They can feel their fascia all wind up in their back and that's why they're having back pain. I mean, yeah, let's talk about it, but there's a little bit more things we need to break apart than just that. Dude, I wish I could just we could I wish I could feel fascia. I wish I could feel it. I wish I could rub my hands on your skin and discern the difference between subcutaneous adipose tissue, like the skin, muscles, fascia, ligaments. But I wish I could feel all that and be able to tell you it's just your fascia. And I wish we had techniques that could assuredly fix the fascia, but we don't. And also, I don't think anyone has the hands of an angel to be able to discern between 20 different structures with a light touch. And so, yeah, not just the fascia.
It's also
Anyways,
just preposterous on its face because when people talk about fascia, I think they're generally talking about the outer layer of your fascia around your muscles, it's like a whole separate layer of skin beneath your skin. But the thing folks neglect to tell you is that individual bundles of muscles within your muscles are covered in fascia. So how are you getting to those deeper layers? Fascia is
yeah,
literally interwoven around your muscle fibers, and there's just like no way you can get to it unless you have a
yeah,
scalpel.
yeah,
And
or
even then,
or a
it's really hard to work through with a scalpel.
or a butcher knife in your case, working on all those deer. Yeah. Anyways, all right, got to lock back in here. Myth number 7: corticosteroid injection is the best first line management for gluteal tendinopathy. I mean, yeah, I don't get me wrong. I've had patients that see orthopedics first. They get a steroid injection to that gluteal tendon. They come in and their pain is already 50, 60, 80% improved. And we just need a couple of therapy sessions to kind of tighten everything up and they're good to go. I've seen, yeah, like I'm sure you've had similar interactions with this, Christian. Like it can be very beneficial for patients. But we know in long term that proper loading, exercises, activity modification, education, etc., like that's your golden ticket to get out of this and to be able to stay out of it because we know that corticosteroid injections aren't forever lasting.
Yeah, I think of steroid injections as adjunct to exercise. Exercise is the foundation of your rehab and modifying what you do, so activity modification, so you're changing your behaviors that could make this problem worse. However, I've made this argument before and I still stand by it, is that I'm open to injections early on for some people, and that opinion really came to me from a lot of conversations with the sports medicine doctors that I work with because they know that loading and exercise is better and that everyone needs to be doing it, but they also have to take a very pragmatic approach in that there are people that come to see them who are driving an hour and a half, 2 hours to come see them. They can't come to physical therapy. They don't have time, or
Yep.
they don't have money, or they have lots of kids and they don't have time because of that, or they've had a bad PT experience in the past and they don't really want to do PT. So they're not going to do exercise no matter how much we know that they're probably the most effective thing long term. And the doctors also have, in my view at least, an ethical obligation to try to help the person in front of them within those barriers and preferences, constraints. And sometimes they have to make the decision to be like, okay, I'm just going to give you this injection. I know it's not ideal, but this is the best thing that I can do for you now when you consider all those other options. And then also, you might say, well, fine, doctor does the injection, but then the doctor's team can then just show them some exercises, give them the advice, send them on their way. And it's like, yeah, that would be wonderful if they could do that. But when you work for a larger corporation, that is not what happens. You don't have, as a doctor, you don't have the luxury of all this time to spend with your patient to do all these different things. And no corporation is going to hire a physical, well, not no, but like most of them are not going to hire a physical therapist to come in really quickly in that same session and teach you all this stuff, because they're not going to get paid for it. Because in order for them to get paid for it, you have to call your insurance company, get authorization, et cetera, et cetera. And so companies just make the decision that we're going to do the doctor visit and then PT is going to be a separate thing. And you can't really have both at once because we can't make money off of it. I'm sure some companies are okay with eating that loss, but most of them aren't. And the company I work for is one of those. And so patients just end up getting the injection and then maybe going to PT, maybe not.
Yeah. And I think in the same sense too, like dry needling, I thought about this too. Like dry needling can be thrown into this. I would say that dry needling is the best frontline defense management style for gluteal tendinopathies. But I mean, it can sure help. I guess, more from a case report level of evidence, have seen from colleagues, myself, that like sticking a needle into the area can give analgesic effects. And so, it can definitely be helpful. But I know in this article, they talk about how exercise, both short and long term, show more superior effects when it comes to managing this diagnosis than just corticosteroid injections alone. But everything that you said, Christian, it puts it into a really, really good perspective of kind of the everyday things that people deal with, like you said. So it can definitely be helpful, but yeah, to say that it is the frontline, first thing, only thing that we should do, we know that something like exercise, we're going to talk about here shortly, is more beneficial. All right, we got 2 more to go. This one I am excited for. I've been waiting all morning to hear your takes on it. And
I think I'm going to let you down. It's not going to be very heated.
Dang it. Clamshell exercises are the best for abductor deficits. I've said it before and I'll say it again. There is no bad exercise. There's only poorly prescribed exercises. And if you come into physical therapy and you are flared the F up, your irritability level is through the roof, and you can barely lift your leg in what's called the frontal plane against gravity because those abductor muscles or tendon is just so dang pinpoint tight, pissed off, right? Yeah. I'm going to give you probably a more simple thing to do, like maybe a clamshell without resistance, just to get things moving, in which case it can be very good for that. But as the article discusses, yeah, later on in the rehab process, if you're 5 weeks out feeling good and you're like, your key to victory here is just keep repping out these clamshells for the next, 2 months. Yeah, probably better things to do at that point. But I think that clamshells have their place. Is it to say it's the best? I haven't necessarily heard people shouting from the rooftops that clamshells are the best exercise to do. But apparently the authors of this article have heard that. But yeah, I think everything has their time and place. And yeah, there's different things we're going to talk about again shortly when it comes to exercises. But what are your thoughts on clamshells being the best exercise?
Yeah, the argument against clamshells or side-lying hip abductions and in favor of doing more functional things like squatting and deadlifting, whatever else, that was a really popular argument when I started working. In 2016, I recall this being all over social media, all over podcasts, and I listened to that kind of stuff. And it got me thinking at the time too, like, okay, am I an idiot for doing clamshells and abductions and side planks and bridges because they're so low level, they're not quote unquote functional? But even then, and still now, I agree with you in that it's all about the timing for the person. You're trying to find exercises that promote the goals of rehab that are also matching the patient's irritability level. If someone is coming into you with 9 out of 10 glute tendon pain, you are not going to give them a pistol squat. You are just simply not. That is a bad decision, and you are probably going to harm the patient. So clamshells certainly have their place. And also, you can load the shit out of clamshells. There's a thing called bands. You can put a lot of bands on them if you had to. Not saying I ever strive to, but like you can still get a pretty decent stimulus. There is a research article I read some years ago that broke down the overall recruitment of the glutes with various exercises, and it used EMG testing, but it also used motion analysis and kinematic testing, and they put that stuff into some kind of computer system that spit out theoretical force numbers at the tendons to make it more realistic beyond just looking at EMG, which we know is not that great. And exercises like single leg Romanian deadlifts and deep lunges, deep squats, those do provide more stimulus to the tendon than a clamshell. And so that makes perfect sense. That's what you want to get to over time as the person feels a bit better. And also, it is our job to choose exercises for you that match your goals and the intended use of your body. If you are someone who just likes to work in the office and maybe do a couple workouts a week, that's the extent of your activity level, and that those activities are pretty chill, I don't need you doing tons of crazy exercises. That's going to be beyond the scope of how you use your body, and it's not your goal. It's not your interest. So I'm going to be choosing movements over time that are more functional, but still in accordance with the way you want to rehab.
Yeah, that's a really good point to bring up too. If you have a collegiate professional level athlete that comes into the clinic and it's like read the room, if you just give them, body weighted exercises the entire rehab, and then, they're probably thinking, I'm not doing anything here. We need to get the ball rolling on some other things. Right. But like you said, if you have someone 50s, 60s that they just want to stay generally active, they have an office job, so they're not super active during the day. They don't have much demand on that tendon outside of, going for a hike or doing a couple exercises per week. Day 2, if you're having them deadlift 80% of a 1 rep max that they've never done before, they're probably not going to like you and not want to come back. So yeah, it's also a little bit of making it appropriate to who your demographic is. That's a really good point to bring up. So, all right, that was a disappointing myth to talk about.
Kind of like the IT band one.
I'm just kidding. No, that was good. That was good. All right, last one, myth 9. All gluteal tendon tears need surgical repair. I guess I'm not too savvy in thinking that the gluteal tendon tears a whole lot. And I didn't really think of the gluteal tendon being like a rotator cuff where it may or may not need repair, but I guess, yeah, it's a tendon. Like that stuff can happen. And so the myth being that all gluteal tendon tears need surgical repair, the article goes on to say that partial thickness tears are common in individuals over the age of 50. It's almost like anything else in the body. As we age, things change. They might change for a little bit in terms of having some tears. And in a lot of people, it's not super symptomatic. And if it is symptomatic, it goes on to talk about how we don't need to be going in and surgically repairing this, that conservative treatment can work well for these individuals, and that should be the first line defense versus surgical repair.
Yeah, and I did like how they said you should be performing conservative treatment for at least 1 year before you consider surgery. And that really comes down to what we know about all tendons is that they take a very long time. The general time frame that I'll say to folks for really any tendon pathology they have is going to be, you need to give this 3 to 12 months. I need you doing dedicated strengthening, progressive loading plan for minimum 3 months, but at least a year, because that is how long we know it can take. Even some studies for different tendons in the body will say maybe up to 2 years for things to really change. And so that's a hard pill to swallow for a patient because they're in pain now. They want to get this fixed, and they're wondering if surgery could get them better sooner, but it's just not the case. And most surgeons won't even touch this until it's too bad. I have a patient right now who has, I think, like a 30 to 40% tear, and the surgeons in the area are not going to touch it. She's talked to 2 of them. They're like, no, it's not bad enough yet. We stand to make you worse by doing surgery. You're more likely to improve by not doing surgery. That is their take, and I highly respect that. It's like, okay, just be honest, set the patient's expectations, and they're just saying hard no. I had a different patient a couple months ago. She just finished rehab with me. She had like a 75% tear, and they repaired it. and she's doing amazing now. She had a great recovery, but that's not usually the case. Usually you're not going to have that bad of a tear, and usually you're not going to need surgery to fix this. You're going to get better. People are like, oh, well, I have a 30% tear. That's bad, isn't it? Like it's just hanging on by a thread. There's not much left. It's just going to keep tearing. I see where you're coming from, but the one thing that you have to understand is that your tendons are not static. They're not inert structures. They
Hmm.
get stronger, they heal. And so while yes, you unfortunately took the tendon too far and it wore out and you lost some fibers that are never going to repair themselves, but the remaining fibers, the remaining 70% can get stronger. You can make those remaining fibers handle more tensile load over time through strength training. And what you can do is you can get so strong in that area that you don't even notice the 30% that are gone. You're fine. You can handle anything you want to do with those remaining fibers. They're strong enough. Your pain goes away. That is a realistic expectation of recovery. And that's something I really strive to instill in every one of my patients.
Absolutely. Flex metal, baby. That's what we're talking about. Flex that resilience. The body's strong. Don't underestimate it. All right. No, yep. All 9 myths. There they are. We kind of breezed over them a little bit just because we don't want to spend all day breaking down every intricate thing. But I think that those are all very good things to keep in mind. And overall, really like this article. I thought it was good. A lot of research to back their different claims on different myths. Some of them, like we talked about, yeah, that seems pretty straightforward. Some of them are a little bit more, oh, yeah, this is interesting. Haven't really thought about that a whole lot. I want to finish off, Christian, just with like tips, tricks, management things. If someone is having, let's say they have a diagnosed gluteal tendinopathy, or they just have this weird lateral outside hip pain that more than likely very well could be a gluteal tendinopathy, what are different ways that we could give them tips and tricks right now to try and manage this thing on their own?
So if it's pretty bad, number one, you always want to start with activity modification. So you got to figure out what are you doing around the time you notice your symptoms, or if you get more symptoms, what were you doing just before that? And there are some common things that we see with people that would be good to know to consider avoiding for now, or at least just modify. One is going to be being in too much adduction, adduction, meaning your knee is closer to your midline or even going across your midline towards the opposite side. That puts a lot of tension and compressive load on that greater trochanter, on that gluteal tendon, and that can make you feel a lot worse. So if you're standing, for example, with your feet together touching each other and your legs are coming down in like a V, maybe you widen your stance a little bit. Take some of that compressive load off. If you sit with your legs crossed a lot of the time during the day, maybe stop doing that for a little bit. If you're sleeping at night and you like to lie on your side and have that top leg just fall down to the table with no pillow between your knees, that's going to make you go into adduction and put more tension or compression on that tendon. And so that's where you might want to roll a little bit more onto your belly to take some of that away, or put some pillows underneath to prop that knee up. All those things are going to help you decrease some of that pain. And then even with walking, people that take too long of steps, too big of steps when they walk, that puts more load on the tendon because you're having to carry your body weight for a longer period of time with each step. And the length of time that you're holding your body up seems to matter more than taking a bunch of smaller steps. And so if you shorten your stride a little bit, take smaller steps, you're going to get less loading on that tendon, which is likely to make you feel a bit better. And then also your step width, kind of like what I said with standing, where if your feet are together too much, you can put more strain on it. If you're walking and your feet are crossing over each other with every step you take, maybe you should widen your walking gait a little bit so you put less work on that tendon. And then the last thing for walking would be, what are your hips doing every time you step? If your hips are dropping or swaying left and right every step, you're putting more work on that tendon than you need to, and you want to try to maintain more of a level pelvis. So what I'll say is, imagine you have your belt line or your pants line. I want that line to stay more or less level while you're walking. It shouldn't be tipping left and right. And if you can maintain that a bit better, chances are you're going to feel better. And that's just with some simple activity modification things. I'm sure we'll get into some exercises in a moment.
Yeah, absolutely. One of the things that the article touched on was, tendons, when they're healthy, they do a very good job at holding and transmitting forces. That's That's the language they speak, right? But when they're maybe a little upset, those different force transferring mechanisms can be quite painful, right? So it talks about avoiding rapid stretch shortening cycles. And so that's going to be seen more with what's called like our plyometric movements. Plyometric movements are they're these kind of rapid, quick movements that we do. So for example, like running, jumping, etc. Talking about avoiding those. Now, do you need to cancel them out altogether? No, I would argue you don't have to, but this is where intricate discussion of activity modification comes into play. So, for example, if you are a long distance runner and you are getting this pain discomfort, well, maybe we do some cross training for a little bit, right? Maybe doing like the elliptical or the rowing machine, whatever feels best. The upright bike, doing like some cycling, sitting, all that stuff. That might not feel the best, but you can give it a try. I would say my biggest thing is like the pain that you feel, very unlikely we're causing like quote more damage to the tendon or the area, right? I would argue we're not doing that. What we're doing is we're just sensitizing it. We're causing the nervous system to be a little bit more sensitive, is picking up on more pain and irritation, and that's where we're getting that excess pain from. So modifying your training, doing more cross training, I think is a good place to start. Or, if you're used to running 5 to 10 miles a day, why don't we do 5 miles, but we do it with a walk jog, or you take it at a slower intensity, you reduce your running pace, or maybe we do 2 miles in the morning, 2 miles in the afternoon. We start to break up these loads so that that area can tolerate it and recover from it a little bit better. So there's ways to still train and stay active and work towards your goals while you recover from something like this. So that's going to be that when it comes to activity modification for someone who's maybe a little bit more active. And then everything Christian talked about as well, kind of with your day-to-day stuff, walking, sleeping, sitting, standing, etc. One of the things that they talked about right away that you could do is, in general, isometric loading is pretty well tolerated in this. And so just for example, one of the things you could do is find a wall in the house and put the affected leg kind of up against the wall, and then try and think about pushing the leg outward into the wall. Obviously, you're not going to move the wall, but you're still contracting those gluteal muscles, those tendons, in an isometric fashion. So it means they're not changing length. They're staying the same length, but we're still loading those tendons in a pretty low intensity way. And those are handled pretty well for the most part. So that's a good kind of starting point, I guess. Like you talked about, Christian, a little bit of stretching, light stretching, low load, not doing anything too crazy, can give some short-term analgesic effect as well. So, pulling that knee across the body a little bit, or maybe doing like a pigeon pose or something to try and just give some light stretching to it that's tolerated, not going into pain, because you're probably going to make it a little more upset in the acute phase. All those things can be well tolerated and hopefully start to see some reduction in the symptoms.
And a major treatment principle, going off of what Eric was saying, is that it's totally fine to go into some pain. And in fact, in later stages of this, it's encouraged, because we know that if you're getting pain in the tendon or discomfort, and it's pretty mild, that you are, in fact, loading the tendon. And that is a signal or a sign that we are doing the right thing for you, and that more of that over time is going to help that thing get stronger and you feel better. We generally, early on, especially when it's pretty pissed, we try to keep that extra pain minimal. So like I'll tell folks, it's okay if you have a little bit of extra pain, but it shouldn't be more than a 2 or a 3 out of 10 beyond the normal pain you already have. And if you do get some, it should resolve by the next morning. That's a good sign that we've introduced enough of a training stimulus, enough load to help drive adaptation, yet not piss it off and ruin your day or ruin the next several days. Because I don't want to do that, because you're going to have more pain at work, more pain doing your day-to-day stuff, more pain at night. You're not going to sleep as well. That's not really constructive for you being a functioning human, and even the healing process if you're tossing and turning all night, because I made your pain worse by having you go into too much pain too soon. And then regarding exercise, I do think the isometrics are really great, because if you think about things like a clamshell, for example, when your knees are touching, you're in that adducted position. You're putting more compression on that greater trochanter and that tendon, and that can be somewhat irritable. And so by focusing on isometric holds before your knee goes too far down towards your other knee, that's going to still get you a really good strength stimulus to make you feel better without potentially pissing off that area. And then we just keep that concept moving into standing. So you're standing, like Eric said, up against a wall, working on that single leg stance, keeping a level pelvis. Then you can turn that more into functional stuff like step patterns or lunging or squats, and you're still getting that hip to work through more of that range of motion over time. So shifting away from purely isometrics to eventually isotonics, which is where you're moving back and forth. And then the major thing for you is we just keep scaling up these different movements that are working by adding more weight, not usually going to a ton of extra reps. I'm not going to have you do 20 or 30 reps on this stuff. That's not really useful for building strength. I'm going to probably keep you in like the 5 to 15 rep range at most, and just scaling those movements up in accordance with your goals and what's working for you and how you need to move your body. So for example, sticking with runners, I definitely am going to want a runner working on things like a Peterson squat or a step up or a step down pattern or a pistol squat pattern, single leg Romanian deadlift, because those are more akin to how they're going to use their body every time they land and propel while they're running.
Yeah, sum that up really well, Christian. This is where it gets to be the fun part of it, I think. Once you get into these later stages of rehab and you can start playing around with a ton of different variables depending on what the patient's goals are and, what activity they want to get back to, like running or weightlifting or, a certain sport, soccer, football, etc. All good things. So yeah, anyways, and then the article goes on to talk about you could add in like shockwave therapy, PRP injection, supplementation, maybe a psych referral. I said, hey, maybe something like dry needling as well. Just different modalities is really all it is outside of activity modification, education, and exercise. There's just different things that we can do to try and just help supplement it, right? Kind of like just taking a page out of Greg Layman's book, trying to empty that cup, lessen the water in the cup. We lessen the pain and irritation, and then over time we build a bigger cup and we make you more resilient, or we don't make you more resilient, you make yourself more resilient. We just kind of give you suggestions on what to do. I don't want to take credit for you doing well. You did it on your own. But anyways, yeah, you just build a bigger cup and you can withstand more load, you have more tolerance, and then you're good to go. So
yeah, I think that's a good way to wrap it up.
Perfect. All right. Well, went a little bit longer than we thought. That's all right.
Half hour,
Half
just planned.
just as we planned. Anyways, all right. Well, thanks so much for listening, everybody. If you have any questions or podcast suggestions in the future, otherwise, Christian and I are just going to keep pumping out these different articles or talk about different interview styles, etc., and go forward from there. So, thanks so much, Christian, for the conversations, and we'll talk to you later.
See ya.
See ya.